Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole, here with Tanner, and today we're going to move our discussion into the realm of all things methadone, and I'll let Tanner introduce our speaker here in a second, but this is often something that I have a lot of I feel like I have a lot of questions that people bring up about using methadone in our practice. It's something that you may not use for every single case, not as necessarily a routine drug. And it's something that I often get a lot of questions about dosing. When would you use it? The appropriateness of using it? How are patients that are using methadone that come to the OR for a procedure, how does that affect what we're going to give? So you have both sides of things with using methadone. And so we thought it'd be just a great idea to do a whole topic about it. So I'll let Tanner introduce our speaker, but we're really excited to bring Richard on and just discuss all things methadone today.
Yeah, so it is. I always love introducing our speakers, but this one's especially sweet for me because where Richard and I met, I posted, this is probably 5 years ago, I posted on Facebook, hey, is anybody in the Greenville area available to take care of my dad? My dad was having surgery. I knew nobody in the area. Richard commented, we connected, and ended up being able to take awesome care of my dad. And so from a personal note, it's been a very sweet story, but then we've just stayed in contact ever since. And if you've heard of us, then you've for sure heard of Richard Wilson. So it feels awkward introducing Richard on our podcast, but he speaks everywhere. He's at every conference, program director, very involved with, multiple organizations. If you guys are familiar also with CRNA Prep Academy, he's involved there as well. So he is just, if there's something CRNA related, Richard's, he's involved somehow. And so we're just honored to have him on. And from a personal note, he's been just a great friend, and we're just pleased to have you on. So thanks for joining us today, Richard.
Thank you, Tanner. Thank you, Cole. Glad to be here. Glad to finally get an opportunity to come on here and join you. Love you guys, what y'all doing for the community, what you're doing for our profession. And I'm just glad to be a part of talking about methadone, because this is really something that, honestly, it wasn't until recently I kind of looked at and started really getting engaged in and how it's being used within our facility. So I'm glad to be able to share this with the learners.
Yeah, you exactly said it. I think, Cole, you mentioned it a little bit when you were introducing it, but it's something that it doesn't really come up that often. And then when it does, I find that we all are kind of like looking at our resources to be like, okay, what do I need to do? What do I need to change? Or if you're doing a big case where it might be appropriate to use it, you're trying to, refigure out dosing and timing and all that kind of stuff. So I think this will be a really timely episode for the learners. So I guess to start things off, kind of what's been your exposure with it? Where do you like to use it? Or what got you, I guess, thinking about diving more in depth with this topic to start with?
Yeah, so I love doing opioid-free, opioid-sparing type techniques. And this has been something that, I'll be honest with you, years ago I got into. I do a lot of orthopedic trauma type cases, especially for a number of years there. And I started thinking about, okay, all I was doing in the past, right? I was basically doing what a lot of people do. And there's nothing wrong with this, but I was putting them to sleep. I was keeping them relaxed. I was reversing them at the end, giving them opioids throughout the entire case, taking them over to PACU, checking on them here and there, through the charts and let them go. And I started going, you know what? Opioids is good in certain cases, maybe, but there's better care we can take of our patients. And we know, and y'all have been in it long enough too, how we start is not how we end with our practice. And so we've seen that transition take place. And so then I started doing a lot of the opioid-free type techniques with some mentors of mine, Tom Barebold, Jason McLeod. I mean, the list goes on and on of those that are doing it that I was reaching out to as mentors for it. And then I started really about a year or so ago, started getting into, well, how does methadone fit into this? So we were not using a lot of methadone in the past, but then we started seeing more of it used. And I was like, how does this fit into my practice? And not just in my practice, but as an educator, how does it fit in what I'm teaching about certain cases and the use of methadone as providers? Because this is not something that we're comfortable with per se. This is not something that a lot of us use on a continuous basis with our patients. So I was like, let's really figure out what all of this is about.
Yeah, you mentioned some big names with Tom Barebow and McLeod, and it's like I think there's a huge push for opioid free, and I love it. I love using all the adjuncts that we can And then it's also like there's a lot of really great resources out there. It might be opioid free, it might not be, but there's a lot of tools in our tool chest, as it were, that we can be using. And I think, like you said, you just get really comfortable doing your status quo anesthetic, and it's good. Patients are happy, but this, I think, is a good episode to kind of stretch our mind a little bit as far as what are the other things that we maybe are not using or underutilizing that we can pull into our practice. So is this something that I guess you're using more routinely in actual patient care?
Yeah, so we started this at our facility. We really started using this more in our cardiac cases, our open hearts, and the pain from cracking the sternum, right? Taking that saw through the sternum and doing all of that goes along with an open heart procedure. And so they were using it in those cases primarily. So then we started kind of transitioning over and saying, okay, where else can we utilize this medication as an adjunct that could be beneficial to our patients? So then we started looking a lot at our big spines and started looking at some of our orthopedic cases. So we really started seeing this transition out of just a single case type, cabbages, open heart type procedures, to then being utilized in different aspects of our care within the anesthetic realm. And so we use it basically either preoperatively PO, or if we haven't given an opportunity to give it PO in the pre-op area, IV right after induction, to really kind of get those receptors taken care of, to block those receptors, and therefore prevent us from having to give just a large amount of opioids during a case.
So you basically primarily were using it for open heart first, and then started using it for other cases. So when you were doing it for like open heart, let's say, are you doing this? You kind of mentioned pre-op. Routinely, were you doing this in pre-op, or were you doing this after the patients got into the OR?
So routinely, our facility was doing this in the pre-op order. So they were giving them PO methadone before they came in, or before they came to the operating room. So they would get in the pre-op area. And they were using anywhere from around 0.1 to 0.2 milligrams per kg. Usually in those cases, they were going to use 0.2 milligram per kg up to about a 20 milligram dose.
Okay. So is this something then that so you said you're primarily using it for your bigger cases, right? Like these aren't like your routine, like lap choles, things of that nature. They're more the bigger procedures. Is that correct?
That's how it is being utilized in our facilities. But if you actually go back and look at some of the studies, they have these studies that are using them in some of those cases that are not considered as intense and that are even outpatient facility procedures. And so they're using them anywhere from about 0.1 milligram per kg up to 10 milligrams total, instead of going up to the 0.2 milligram per kg, using it usually on your ideal body weight. And so they're seeing really good results without delaying recovery, delaying a discharge from the PACU, even in those outpatient surgery centers.
That's crazy.
So
I would have thought that it would be like open heart. Totally makes sense to me. I've used it in spine before. But yeah, I had no idea that it was being used in, like you said, what seems to be considered like a less aggressive surgery. In your experience, because we can all say like, why, like the cases are going fine with what I'm doing. Why, like what's the tipping point, or what was the tipping point for you that was like, this is a better option? What was it? Like better pain control? Was it better just, patient recovery, being able to wake up faster? I guess what was the tipping point where you're like, this is not just an adjacent track, this is a better track?
So for me, it was better pain control. So I started reading these studies, or looking at all this information, and even seeing how we were utilizing it, our facility was utilizing in the open heart cases. And it seemed to be providing a better pain control overall without having to dump a bunch of fentanyl or a bunch of Dilaudid, within the patient. And I'm not saying there's anything bad about those two drugs. Honestly, it's just, this was something I felt like, okay, we're seeing longer acting, and we can talk about that long action of this, but we're seeing it as a longer acting medication. So where Dilaudid would wear off eventually, right? Every couple of hours or so it'd wear off. You've got something here that lasts a much longer period of time, blocking that opioid receptor. Therefore, you're not having to really keep giving a narcotic. And think about it. Every time you give a narcotic, what happens? Those receptors within the brain get stimulated. You get that high, and that puts them at an even more risk of developing addiction to these narcotics, to these opioids. So if one's got something that blocks the receptor and blocks it long term, And therefore, you're not getting that up and down, and they're feeling that high. That's a benefit to these patients, right? Because you've got a longer, more consistent control.
Yeah, it's interesting because I remember when I was in school, I had a preceptor, and I'll forever thank them for this, but they had me draw out, I'm coming into clinical. I think I got my stuff together, I'm doing great. And they're like, hey, would you do me a favor, draw out the time map for each of your drugs that you're giving? So we're doing an 8 o'clock case. You just gave fentanyl. It's 8:05. So I want you to draw out where that fentanyl is going to taper off. All right, you just gave some Dilaudid. I want you to show me where that's. And the point they were making is like, you're the airway expert, you're the pain expert. And what you're really doing when you're giving these shorter acting medications is transitioning that expertise to somebody else. You're putting in an order set, but you're leaving it up to somebody else to manage that. And they're like, well, you should be thinking longer term about what's this patient look like if it's a 2-hour case. What's this patient look like at 10:30? What do they look like at 11? What do they look like at 1 o'clock? And it was the first time in my brain I'd ever really thought past, hey, this is a high heart rate, high blood pressure. I'm going to fix that with some fentanyl. And then, my case looked smooth. My vitals looked great, but I had no like forward thinking. So what kind of timeline are you getting from giving, if you say you're giving a 0.2 per kilo dose in pre-op, what kind of timeline are you looking at for keeping those receptors covered?
Oh, you're looking at hours. I mean, you're looking at definitely hours. And that's one of the key things to remember is because when we start thinking about giving these medications in the preoperative area or even shortly after induction of anesthesia, right? We've got to really pay attention and think about it as, okay, well, I cannot manage this case like I normally have in the past, because if I do, then yes, I obviously am going to have a delayed wake up because now I'm adding something in that is going to block those opioid receptors. We're going to get sedation from it. We know that for a fact. And so if I just continue to give Dilaudid throughout a case like I normally had, then obviously this patient's not going to breathe at the end. And if they are, they're just going to be completely asleep at the very end, and they're going to be hard to arouse. Again, delaying all of those things we want to do in the recovery period overall. So we really got to think about, okay, if I'm going to be using this, what part of my anesthetic do I need to kind of cut back on or taper back on a little bit to really compensate for the fact that we're going to get great pain control here. We're going to get the fact that it does have the sedation, not just the analgesia side of it, but it has the sedative part of it too. And so we've got to really pay attention to that.
So what kind of changes then are you making for a procedure? So let's say, open hearts for me that I do right now. If I'm going to be using sufentanil, I might be using 100 mics of sufentanil. I'm also using ketamine, Precedex, things of that nature. Or I might be giving 500 to 1,000 of fentanyl. When you give methadone for those, how then are you adjusting how much extra you're giving? And I guess this probably also depends too on if it's had time to set up before incisions being made and things of that nature. But if you're giving it in pre-op, theoretically, it should be set up by then. So how are you altering, I guess, induction dose versus, like, are you giving any opioid on induction, or are you letting the methadone do its job, and then are you giving any more throughout the case?
So I have a practice where I actually don't give any narcotics on induction of anesthesia. I know that's a little different sometimes than what some people think, but for me, induction of anesthesia, it is a stimulating event, don't get me wrong, but it's a very sympathetic, it's a short-acting sympathetic stimulation event. And so I usually don't give narcotics on that end of it so that it doesn't keep me in a hypotensive state when I don't have a stimulation going on when we're sitting there waiting for surgery to start. Mm-hmm. But what I have seen in my practice, and I'm just going to gear towards orthopedic trauma for an example, because I do a lot of orthopedic trauma cases, is what I really have seen is by using this, and I use some lidocaine, ketamine, and Precedex, I literally cut back on all of those dosages now. And then even on the opioid side, I don't give any opioids until if I'm going to use something, I'm not using it in my anesthetic. I'm actually doing something that Tom and Jason have talked about in the past, is focusing on the postoperative analgesia side and only giving something on the postoperative analgesic side. But again, if we've only been an hour or two in the surgery, 2-3 hours maybe, I'm rarely giving anything at the very end of the surgery. Now, if we've been a little bit longer, I might be titrating some Dilaudid in, but again, not until the very end of the surgery. So it's really made me think about it, because Normally where I run ketamine at around 4 mics per kg per minute, dexmedetomidine at around zero point 0.5 mics per kg per hour, run lidocaine at 2 milligrams a minute. Now that if I've thrown methadone in on top of that, what I do is I cut back on my ketamine dose, usually till about 2 mics per kg per minute throughout the case, and then cut back to around 2 to 3 mics per kg per hour on my dexmedetomidine throughout the case, because I know I've got that methadone on board and I've got that consistent blockade of those opioid receptors.
So you're basically cutting, I mean, it's cutting your drugs you're giving basically in half. And then you're also talking about not giving or not needing to give opioids intraoperatively. I think this was another moment for me where, like, I remember thinking, okay, like you said, giving fentanyl on induction or giving an opioid for induction. I remember thinking when I was working on those time maps, it's so helpful for me to think of, like, these are all just tools. And if you give fentanyl up front on a case, I tell students this all the time, that is just a tool that you gave. You're not giving them any analgesia properties for recovery or for the rest of the case. I mean, you're covering those receptors temporarily during the intraoperative period. So there's going to be, benefit to that when, as far as managing vitals and those types of things. But if there's other tools that you can use, that's going to be well and gone by the time you get, on to the next thing. And so if you can find other options to use during the case, and then, like you said, just covering some analgesia for post-operatively, yeah, I love this idea because they're all just tools that we're using. And if you can use esmolol for induction just as well as you can use fentanyl for induction, like there's less side effects or less issues with hypotension and things following the induction of anesthesia. And so, I think a lot of times we go through the motions and just give fentanyl or give Dilaudid just because that's what's we're been trained to do. But there's a whole broader picture here that's involved.
And we have to think about it too, is when we're giving those other opioids along with this, right? Or just giving the other opioids on top of each other, you got to think about the respiratory depression that it's causing, right? And so really, when you look at the studies on methadone, they've got studies out there on pediatric cardiology patients and the effect it has on peds cards. It's got effects on the morbidly obese patients. It's showing that it's better when methadone is thrown in there and used on the morbidly obese patients versus just using opioid type techniques. So there really is a lot of benefit and a lot of good studies out there on a wide variety of patient populations. I'm like you all. You throw methadone out there, especially a couple of years ago, my first thoughts are, okay, substance use disorder patient. We're going to use it because it's a substance use disorder patient, right? Or we're going to use it because it's this long, drawn out, major 7, 8, 10 level spinal surgery, or the cabbage where you're cracking the chest open. But they literally have studies out there from pediatric cardiology to outpatient to morbidly obese. I mean, you name it.
So when you're giving the methadone, then you said it's shaped your practice where you're cutting back on your anesthetic. Are you, like, the percentage of time now that you're actually having to treat bumps in sympathetic stimulation throughout the case, is that blunted quite a bit? Or are you still having the periods of on incision, they spike 20 points and you're doing something other than an opioid then at that point to help? Or are they pretty smooth at that point all the way up?
Usually for me, they're pretty smooth. Now, I will say this. I am not going to sit on this podcast and lie and get called out on anything, right? And the fact that, that I started throwing methadone on these patients and started using it and everything was just as smooth as it could be from there on and nothing ever happened, right? We're not going to go there. Because anytime we make practice changes, we have to understand as practitioners, there are going to be bumps in the road. And we just got to be able to think about, okay, then what am I going to do next time? Now, my bump in the road, to be honest with you, was hypotension. Because, again, using anywhere from a half of mac of gas, but also using lidocaine, ketamine, and Presidex, then you throw methadone in on top of that, and you're decreasing that sympathetic stimulation response. Based on all of that, yes, I was getting hypotension. I might have to actually bolus a little bit with some norepinephrine or something. Norep is my drug of choice for those hypotensive events. But I was not seeing those spikes that we're talking about, right? Where if they were manipulating the bone, manipulating the femur, the tibia, if they were just making incision and starting to separate the muscles, I was not seeing those spikes. I was not having to throw extra Dilaudid or anything at them on a usual basis.
Yeah, I like that, and especially as Tanner, you mentioned with your time map. You never told me that story, by the way. Going through school, I never heard that, but it makes a lot of
Always
sense.
had to keep my
Hey,
edge over you, Cole. If there's anything I could do to keep an edge over you, I'm not sharing
actually,
that
Cole,
information.
he was waiting until I got on here. He felt like it was a special story for
Yeah.
me. So,
Yeah, exactly. Yeah, this is a safe
But
place now.
but it's so true though. I had a resident the other day with me that I was explaining to them just the idea. We were struggling with hypotension in a patient, and it was a neuro case. And I basically explained he was still running a full MAC on the patient, but I said, okay, now you've given long-acting opioids. We didn't use methadone, but we were using. He was used to using a lot of fentanyl. And we added in Dilaudid into there. We also had Precedex running, and then some lidocaine running as well. I said, you have to factor in all of this combines into your overall MAC, your overall anesthetic. And so you have to lower what your gas is to establish what your full MAC is through all these tools you're using together. So that was going to be my next question for you is with doing methadone behind the scenes the entire case, are you lowering the amount of volatile agent that you're needing to use? But again, I guess you kind of answered that with your adjuncts like
yeah,
Precedex, drip, et cetera, you're cutting back on.
yeah. I'm cutting back on those. Again, I don't even run. I rarely run above a point 0.7, point 0.8 Mac of gas on anybody anymore because I'm usually have adjuncts I've got in there. We have to remember when we talk about Mac of gas, and I know this episode's not on Mac of gas, but it does play into methadone and everything else. Is when we talk about Mac of gas, that was actually derived, I can't remember how many years ago, but it was based on volatile anesthetic agent alone, not using adjuncts with it. So once we add adjuncts in there, we're getting amnesia. And we've got to remember, what is the goal of a general anesthetic? One of the goals, especially using the volatile anesthetic agent, is the amnestic part. And so, we had methadone in there. That's sedation. That's going to get us, again, part of the quote unquote MAC of our patient or contribute to the MAC of our patient. But not only is it acting on the mu opioid receptors, it is a NMDA antagonist also. So that's why we can also cut back on the ketamine a little bit because we're already working on that NMDA receptor with methadone.
I actually didn't know that. I knew about the opioid receptors. I didn't know about the NMDA receptors. That's pretty cool.
Oh, I guess you didn't learn that in school, huh, Tanner?
Yeah,
But
if I
I
did, I
remember
would know
learning
that.
that in class.
Yeah, you do. Of course you do.
No, but to be honest, though, I forgot about that too, actually, until you said that, Richard. That makes a lot of sense then where you can cut back on ketamine from that.
Yeah.
So
And when you look at it too, it's got some effects. If you look at some of the literature on it, it inhibits serotonin and norepi uptake. I mean, think about all of that we're talking about right there.
yeah.
Yeah, maybe would it be helpful just because I know a lot of people, at least where I work, we don't use methadone very often. And in clinical for my program, Tanner and I program we went to, I personally did not get a lot of experience with methadone. So would it be helpful I know we're talking about this from different angles. Would it be helpful just to spend a couple minutes describing the actual mechanism of action and how it differs from fentanyl or Dilaudid from that standpoint? Because you're adding in the NMDA, norepinephrine, reuptake, things of that nature.
Yeah. So, I mean, when you look at the opioid receptors, right, we've got to think about what goes on at those opioid receptors. And you can have partial blockade, you can have a full blockade. When we look at something like Suboxone, that's a partial. When we look at something like methadone, that's a full opioid agonist or antagonist, right? So when we start looking at these receptors, we also got to think about what is released at these receptors. So even if we're just looking at the opioid receptor side of this, and we start thinking about all those receptors that are associated with opioids. I mean, we've got the mu, kappa, and delta. And so what is released from the mu, kappa, and delta? We get substance P. Substance P is one of those neurotransmitters, right, that kind of ramps you up. It's one of those neurotransmitters that's really involved with the pain. So what we're seeing is a release of substance P to go act on the neurokinin receptor. And so we see that aspect of it. Now, when we start talking about NMDA antagonists, just think about what happens with that dissociative anesthesia. And remember, years and years and years ago, ketamine was not used in the operating rooms, except really if you had induction of anesthesia, potentially in a trauma patient that was severely hypotensive. To where they started finding out that, hey, if we start acting on this NMDA receptor or doing something that's acting on this NMDA receptor, potentially affecting glutamate, then what we're going to see is also a analgesic effect that can occur from that. And so we started seeing that. And then you start talking about norepi uptake. I mean, think about what happens when we start talking about serotonin and norepi uptake. These are also our neurotransmitters that if we can block the reuptake of those, what are we doing? We're calming the system down. So instead of having all of these things that are ramping up, I mean, we're hitting really that sympathetic nervous system side of this from multiple different angles, which is really good. Now, the problem is we've got to worry about is that when we give it, there is a longer duration of action than what we're used to out of our normal opioids that we've been given in normal narcotics. So we've got to remember that duration of action and understand, okay, well, where I'm used to a patient that usually if I've given 0.5 of Dilaudid in 45 minutes, maybe, they're going to start having some pain again, and I'm going to have to really kind of redose the Dilaudid. This is something that's hours and hours and hours. So we've got to get comfortable with the fact that, hey, I'm sitting here and I'm not giving anything. That becomes difficult at times because we always want to go, oh, well, and I've seen this happen before, is, hey, it's been about 45 minutes to an hour. I've not given any Dilaudid. Maybe I need to give some right now because this has got to be wearing off, right? Get back to Tanner's time maps that he is so proud of. Then we look at that and we got to figure out, this is okay. I don't need to give anything right now because metabolism also varies. Now, when we look at the metabolism side, because of the way that it's processed in the liver, and we look at the cytochrome system, right? The cytochrome P system that actually does this one. This is 3A4. It varies among everybody, and so we see different durations of actions from the methadone. So we've got to be able to just say again, we got to get comfortable sometimes when using this. Just sit on my hands.
So it's not a difficult pitch to give to people, and just give this and you can sit here and relax a little bit more. You sold me already.
Exactly. I think that's it for this podcast episode. Yeah. Thanks for joining us. Yeah. So let's talk a little bit about what it looks like, because I have a few more questions about this type of therapy when we're using Intrarop, but I want to circle back to it after we talk a little bit about what does it look like when patients are on this, long term, and then they come in to have surgery done. We talked a little bit about this. We've covered methadone, Suboxone on a different podcast episode, and we've also talked about the pain pathway. So if you are a little bit confused about some of those terms that Richard's using, go and listen to those episodes too, because we spend a little more time. We just don't have time to go through all of that today. But let's talk a little bit about, okay, you've got a patient that comes in and this is on their med list. What does that mean for us in terms of managing these patients intraoperatively?
So years ago, and that's a great question, because years ago, we would just go, I don't know what I do here, right? We would just be like, yeah, I'm throwing my hands up. We're going to hope for the best. Maybe they shouldn't take it coming in, and I'm just going to give them some opioids, but I'm going to be careful with how much I give them, or am I going to give them more? We really did not know or have a great plan on how to move forward with that. Now what we're seeing is a lot of recommendations. Hey, if they're on methadone, continue their regimen. Don't take it off because they're on it for a reason. And if they're on methadone and we take it away, then how much narcotic do we have to give to actually cover what the methadone was covering? And again, putting them at higher risk of relapsing at this point in time. I'll tell you, I had a patient came in a couple of months ago that we were doing a major orthopedic case on. It was an orthopedic trauma case. It was going to last for about a good 3 hours or so. And he had in his history, I'm a substance use disorder patient, and I am recovering from that. And I was like, sounds like we probably need to use some methadone on you. So that's what we did, was we gave him 0.2 per kg of methadone preoperatively. And I think if I remember correctly, again, 3-hour case, I think I gave around 0.5, maybe a milligram of Dilaudid at the very end of the case. And that was it for the entire case. And no regional anesthetic block, used my lidocaine ketamine Prestex. So we see where in those types of patients, it has become very beneficial. Now, I did a presentation on methadone at one of the conferences I was at. And one thing that they recommended, and I thought this was actually a very, very good recommendation, that sometimes we as practitioners overlook, whether we are, CRNAs, anesthesiologists, whatever it may be, in the pre-op clinic side of this. we need to be contacting their prescribers and figuring out, okay, why are they on this? And what is the risk of this patient if they're taking off of this prior to surgery? Now, we're seeing a lot more people say, hey, continue it. Do not discontinue this medication prior to going to surgery. Just know what the effects are as you're going through the surgery. Again, if they took this methadone an hour before they came in, 2 hours before they came in, 5 minutes before they came in, have that in mind. But we're seeing a lot more of that continuation. But I thought that was a very, very key point is, hey, if you got questions about it, reach out to the person who prescribed it and find out what is going on, why they prescribed it, and what their recommendations are based on the type of surgery the patient's going to have.
So just to make it clear for everyone, so you have a patient that's taking methadone chronically for some sort of chronic pain that they're going through. So they come in, we're obviously not going to stop that because we don't want them to relapse and we don't want them to have to just hit them with a ton of opioids to both compensate for their chronic pain plus the pain of the procedure that we're doing. Mm-hmm. So now that you have, let's compare patient A to patient B. Patient A, we've already talked about. They're coming in not on methadone. A patient that's not chronic pain, you're going to give, 0.2 out in pre-op per kilogram and have that go all the way through your case. Let's say you're doing a back procedure. Now you have patient B comes in chronically taking methadone. They're taking their normal dose. Do you give them an extra dose on top of that with the extra pain that you expect them to go through with the procedure? Or are you using other forms of medication from an opioid standpoint? Or are you purely still relying on that methadone as your opioid base? And now you're using your adjunct therapy potentially more than you would in patient A.
So in the one that's on methadone prior to coming into their procedure, I usually won't redose on top of their methadone. So kind of let their methadone dose be what they have overall. And then I'm using adjuncts, again, the lidocaine, ketamine, the Precedex. If I start to see spikes occur within their sympathetic nervous system side, whether it's manipulation of, organs, bones, whether it's incision, I usually will treat that with a little esmolol to start off with, 30 milligrams of esmolol, something like that, to see if it's just one of the short-term sympathetic responses versus just throwing an opioid in there and treating it, assuming that it's pain. And then if I see that kind of resets the system and then we're kind of calm back down on the sympathetic response, then I'll just let it be at that point in time. If I see that, hey, this is not working, I'm getting another surge in sympathetic response, I still usually will not throw an opioid on. I usually will then adjust something like my dexmedetomidine, my Precedex dose, and go up on it from maybe, if I'm at about a 0.3, I may go up to a 0.5 on it and see if we can kind of, again, treat that because we've got to look at, obviously, peripheral and central sensitization that occurs in trying to approach that pain from different aspects.
Do you find with either patient A or patient B that you have any increase in, I tell people all the time, if they have like a block, I say, this block's not all or nothing. Like it's going to go away slowly. So I want to make sure when you're starting to feel discomfort from your shoulder or whatever, that you start taking some medications to get on board before you feel the full weight of the surgery that was done. Don't let it fool you thinking it's no big deal. As that wears off, start taking those medications. Do you see any kind of rebound with these patients that they've been, so comfortable throughout the case, and then when all that wears off, they are requiring more opioids after that? Or if somebody comes in and they're on, methadone already, and then they get through the case, and then afterwards you see an uptick in the amount of narcotics that are needed to be given post-operatively? Or I think I know the answer to this question, or does it go the other way?
So I would say, it's going to be patient specific, obviously, but I would venture to say, and I have not seen a lot of narcotics used post-operatively. I followed a number of my patients through their charts for probably 24 to 48 hours after surgery, just to see how these things work, right? Because I'm one of these that if I'm going to try something a little different, I want to know if it works and if I should still keep using it or just abandon it overall. And so I wouldn't say that I've seen a lot more narcotics used because of methadone and then it wearing off completely. I think what we have to think about is, when is the pain the worst? So let's take the patient that has not been on methadone prior to coming in. They come in and have surgery. We've given them 0.2 per kg before we go back to the operating rooms. When is that pain the worst? That pain is usually the worst immediately after surgery. And then as it starts to build up, usually by the time methadone has worn off on the opioid side, right, on the opioid sparing side of this, then this patient's going to be able to say, hey, I'm starting to hurt a little bit. And then it can be treated by the PACU nurse, the floor nurse, whoever it is. So once it's starting to wear off, that's going to happen, right? That you're going to be able to give them something for pain in the PACU or on the floor, whatever it may be. Now, when we start talking about it in the substance use disorder patient or somebody that has been on methadone for extended period of time, again, we're trying to match their dosages, or I would consider matching their dosages and see when do we need to give more narcotics. And so is there a risk of that? I would say, physiologically and pharmacologically, I would say, yeah, there's probably a risk. There's probably a chance that if you're not matching things, right, if you're not following this and you're not thinking about the timing of when you're giving your medications, that you may have to give a little bit more narcotics. But that's also if you're just completely saying, hey, I'm just depending on methadone and that's all I'm depending on, and there's nothing else that I'm depending on for pain control in these patients.
Yeah, that makes perfect sense. One thing that I did want to come back to, because we mentioned this a few times, and so I think it might be important just to explain this. When we have a patient that comes in with history of substance abuse, substance use disorder, why do we want to use methadone as compared to several of our other options that we could use?
Well, I mean, for me, when I start thinking about substance use disorder, what is usually the reason they're having substance use disorder? One of the primary reasons is that high they get. And I don't know if any of you have actually had an opioid, but I've had multiple surgeries. I've even had a couple of orthopedic surgeries. I've had about 5 or 6 surgeries in my young career, right? And during these surgeries, I specifically remember in a couple of them, an opioid being administered to me in the PACU or on the floor. And I'm not ashamed to say this, and I'm very thankful that I'm not suffering from substance use disorder, because I think we're all, at risk for it, especially if we're taking opioids. But I can remember when I was given Dilaudid, I can remember the high I got pretty immediately. Now, granted, it was a 2 milligram dose they gave me immediately post-operatively, but I remember how quickly, and I was like, man, that's a good feeling, and it really messes with the brain. So if we're giving something that doesn't have that high, right? It doesn't have that high as consistently. So every time I got Dilaudid, guess what was happening? I was getting that high. So if they were giving me a 0.5 milligram, 1 milligram, or 2 milligrams, I was getting that high every time. And so when we start using things like methadone, we're avoiding that repeatedness of getting that feeling. And that is part of the feeling of why people end up suffering from substance use disorder, is because of that good feeling it gives them.
And you can probably attest to this, but I've had several patients that come in with substance use disorder and they are just adamant, like absolutely no narcotics. I don't want it. Anything you can do to avoid it. And, you realize like the illness of addiction and having that high that you feel, it's like, it is something that is so gripping on a person. And when you were talking about that, Richard, like I had my ACL done a couple years ago, and I remember, afterwards, like you definitely feel way, way, way better after you take your narcotic when you're home and you're in pain. Obviously your pain goes away, but like you feel better. It's something that is globally happening to your body, your brain, that when you take an opioid, you feel it. And so if there's ways that we can avoid that, and I think that too, like I hear patients all the time. Literally yesterday, a patient said this to me. She's like, "Oh, did you give me any fentanyl? Fentanyl makes me just so nervous." I have a friend that has been addicted to fentanyl, and my response was, yes, we use fentanyl, but it's very controlled. We use it in a very specific way. We're watching all your monitors, and we use it for a very specific reason. Nothing that you should be concerned about. But on the other hand, like in the back of your mind, you're also thinking like it is like there's dangers involved with every drug that we give, and there's opportunity. Anytime that you're giving it, there's an opportunity for that to become an issue. And so, yeah, I love what you said about kind of just the experiential effect of having those opioids, and if we can bypass that completely for patients, or mostly for patients, just what a better option that could be.
Yeah, and we think about it too on the acute and chronic pain side. I know y'all said y'all had, some sessions on that, which is great. But when you really think about it, whether it is a substance use disorder patient, but that was taking it because of chronic pain, or whether it's just somebody that has had surgery and you're worried about chronic pain developing. I mean, we think about pain within itself, and you got to think about the anxiety that comes with that pain, and the anxiety that comes with that pain actually causes more pain in the long run. And this is how a lot of chronic pain can develop over time. And this is how you get changes in the nervous system that develop and the chronic pain develops. It can be that vicious cycle that we see with anxiety, pain, changes in the nervous system, more anxiety, pain, and it just keeps going. So if we think about something we can give that's a little bit longer acting, and again, we're not re-stimulating that and continuing that cycle, we are making a difference in the patient's lives.
Yeah, it's amazing. I think for this episode, I know there's 10 different avenues that we could keep going to discuss more and more things. But before we wrap up, is there anything else specifically that you think would be helpful for listeners to know about if they're going to incorporate this into practice, or maybe some other points we haven't touched on yet?
No, I think really, as you look at it, the key points to remember is this can be used in any type of surgery. But the thing is, you got to remember the dosages. 0.1 milligram per kg to 0.2 milligrams per kg. And usually if you're doing something that's of a shorter surgery procedure or outpatient, you want to use closer to the 0.1. If you've got the bigger surgeries, longer ones, and they're going to be inpatient procedures, you can go up closer to the 0.2. Also remember that, this is a full opioid agonist. So we're going to see the same effects that you're going to see as giving the opioids. It's just one of these that really has a much longer effect. And it's not just acting on the mu opioid receptors. I mean, we're acting on the mu opioids, but we've got the NMDA antagonist capability of it too. So it's doing a lot of great work there. But again, it's one of those things that you really you've got to get comfortable. And the only way to get comfortable is to start using it, to start using in your patients. And then obviously, remember that when you are using this in your patients, or your patients have had this, that it really is going to affect potentially the amount of anesthetic gas, inhalational agent, or adjuncts that we're using overall within a case.
Yeah, the one last thing I wanted to ask about is, do you see any increased need for Narcan or anything towards the end of a case where you're just having trouble waking a patient up or getting them back breathing?
I have not in the practices where I've been using it. Again, I don't use opioids throughout a procedure. And so I usually wait till the end. I usually wait till, honestly, I got them back breathing at the end of a case and I've been able to assess them. And I don't use respiratory rate as my only assessment. Now, I'll look at it, but obviously that's not something. And if you've been familiar with using opioid-free, opioid-sparing type techniques, these patients will come back breathing 30 times a minute, and that's nothing abnormal. And then they'll eventually just kind of settle back down into a lower respiratory rate. So I usually look at it as, again, how long have I done this, or with the patient, what are my vital signs are looking like, what is hemodynamic status looking like at the end of the case, before I start just titrating in narcotics at the end, especially if they've had methadone during the case. It really puts me on notice to say, hey, even if I've been using, usually in these cases, a 0.5 milligram at the end of a case, I may want to consider only 0.25 or none at all. Let's just see how this patient is when they wake up from the anesthetic.
Awesome. Well, Richard, this has been a wealth of knowledge. Thank you so much for coming on and talking with us about this. Again, as I mentioned at the beginning, I feel like at least the area that I practice in, it's not used as frequently. And so it's something that I feel like a lot of the practicing CRNAs and also SRNAs in our area just don't get to experience very much of. And I think, as you hit the nail on the head there, like the only way to get comfortable doing it is to start using it on your patients. And yeah, you've been a wealth of knowledge just explaining all of the data, the research behind it, the benefits from using it. So it's definitely something that I'm really excited about to try out in my practice and hopefully start to change a little bit of how I take care of some of these patients.
Well, I appreciate y'all having me.
Awesome. Thanks, Richard. Appreciate you.